Good afternoon for all those who have joined in, and good morning to our colleagues in the US. We'd like to welcome you again today on our 11th Pediatric Emergency Medicine Lecture Series. And today we're going to be having another good, interesting topic, which speaks about emergency medicine in general, but it could also be applied somewhere else. But today we're going to focus more at emergency, and the topic is going to be about quality improvement in emergency care settings. And we are happy that we're going to have two of our presenters today. We're going to have Dr. Bola Akinsola, an associate professor of pediatric and emergency medicine at Emory University. And we're going to have Dr. Ali Akrabi, who is an emergency medicine physician at Bugando Medical Center, but also a honorary lecturer at MUHAS. So let's all be tentatively, let's listen. As of now, you cannot mute and speak, but if you have any questions or you will want to have any clarifications, you can just put it on the chat. I and Dr. Brittany will follow up the chats and will let the presenters know at the end of the presentation. So I'd like to welcome you once again to this nice presentation that is being prepared today. Dr. Bola and Dr. Ali, the floor is all yours. You're welcome.
Thank you.
Thank you very much, Dr. Humphrey. I'm Dr. Ali Akrabi, and I also want to welcome my colleague, Dr. Bola. Introduce yourself. Okay, so I welcome everybody to this very narrative and very broad seminar or the webinar, and we're going to summarize as we highlight that is the small changes, big impact, improving the care through quality improvement. So what is quality? Quality is a set of activities that will fulfill the requirements that is required. And in this, we are going to take you through to the definition of the quality improvement and to recognize its importance for driving effective change. But I'll also take you through how to differentiate from the QI from quality assurance and research. And my colleague, Dr. Bonlale, will take you through the QI framework and the tools that you may use to assess your QI project. Next slide. So the quality improvement, it is the strategy to improve the quality in stages and processes through continuous study and interventions. Quality is all about doing the right thing at the right time, in the right way, for the right people to get the possible results that you want. And through improving the processes, that is the actions you assess and improve, you can also improve the system. These are the multiple processes that you make, you improve to make a system improved. But it also improves the efficiency and performance over time. We optimize the resources to get the good outcome, and also the effectiveness for the outcome that we want to achieve. This is all about the quality improvement. For example, if you want to improve the teamwork, this is the quality improvement that you're going to assess, study, and you intervene. Improving about the information and feedback to patient and the relatives. As you know, if we involve the patient and the relatives in their treatment, we may be able to get them informed and get the consent for us to proceed with the treatment. But also another example could be interdepartmental consultations. Next slide. So what about the quality assurance? The quality assurance may be different from quality improvement, although it also measures the processes and the system. But here we're looking at the compliance. There's already set standard that you are looking that there are no defects that happen against the standards that have already been set. For example, if there are the guidelines that already been set, the hospital protocols, the government or the Ministry of Health protocols or the guidelines that already set in a certain area, and that's what now you do what we call quality assurance to see how compliant are the settings into the standards, and it focuses on consistency and prevention of the defect. We prevent the defects that may go against the standard. But the quality control may be interchanged somehow with the quality assurance, but this is more of the looking at the service or the product that has to meet the standards and has no defects. And for example, if you are looking at the laboratory results, these should be calibrated in order to provide accurate results that you need on the results that are intended to get. But also, what about the ECG? The ECG can also be the quality control has to be calibrated so that it can provide the accurate results for you to interpret. Next slide. The research is a systematic investigation to study of the of materials or the hypothesis that you want to establish if you want to approve or disapprove the question or the problem in mind, and can also provide new information. It can be you want to study on the medications restocking or the medication use in the emergency department. But the research can be applied in a certain setting that you cannot apply in everything, like in a quality improvement can be very short time and it's a direct effect. When you assess the quality improvement, you assess the quality, it can go on altogether with the actions or the interventions that you have to intervene to improve the outcome. But in a research, it takes a longer time that you have to develop the proposal, go through the ethical approval, then start to study before you come to conclusion. And then if the hypothesis now meet, then you start to change your practice. So quality improvement may be a better one in improving something that you want to do in a short time. So it doesn't delay time. And also you may use a wider subject. In a quality improvement, you will have to involve, let's say, the department, the emergency settings, that involve the whole department, that they have to be responsible or they have to be assessed, and everybody should take part in the improvement. But in a research, you only take the sample of the people that can generalize the whole population. So that's how the quality improvement may be a better in a short action. Next slide. So the importance of the quality improvement, why QI matters, why do we do it? QI matters, the quality improvement may improve the patient outcome. When you go through the standardized care pathways, let's say the guideline or the protocol, you can look at the compliance, and you can also provide the intervention that may bring the services that is to the standard, but also evidence-based intervention and early recognition of critical condition. For example, the study that was done at Muhimbili in 2016, after 2 years after the implementation of the training on the vital signs directed therapy, how to identify the vital signs and the danger signs at National Hospital, ICU, by then was a 6-bed, using the nurses to monitor the patient. And it involved about 18 patients and about 1,920 of the vital signs that were recorded, and about 280 danger signs. It shows there was a good adherence to vital signs identification and following the protocol of the vital signs abnormalities with the actions that have to be taken, from 2.9% before the implementation to 16% after the implementation. And 2 years, when you do the QI, it showed that there was a good adherence up to 30%. So this shows what? Although it is an indirect effect to the mortality, but recognizing the vital signs and the danger signs will improve the mortality of the patient. Next slide. QI also can help in the optimization of the resource utilization. So by streamlining resources, you may avoid or decrease unnecessary tests or interventions and enhance the patient flow. The study done by Terry Reynolds et al. In 2015 at Muhimbili in 2012 showed that the focus at the emergency department improved on diagnostic impression and patient flow. The patient who had an improper disposition, the focus or the ultrasound improved their disposition, but also it in other studies show that focus may reduce unnecessary imaging costs like X-rays and the CT scan. Next slide. The other importance could be continuous improvement. As you grow through the culture of evaluation, to adapt the new best practices, you can continuously improve the service or the outcome at your area. Before the emergency medicine practices in Zanzibar, like this study in 2012, show that improvement in the door to physician assessment was done to improve the service of the emergency care. And in Zanzibar, at the national hospital, Nazim Moja, they did a PDSA cycle, plan, do, study, and act study, which will be elaborated later on to improve the service, and that included to improve the registration process, to make a simple triage process for the patient to be triaged and seen by the doctor. So this can improve the service and the mortality. Next slide. The QI can improve or can enhance the patient experience, customer satisfaction, and through effective communication, family-centered care, customer care, and all these processes, the patient flow. If this is improved through the QI projects, then you can improve the customer satisfaction and increase the volume or the income of the facilities. Staff engagement and empowerment. The recognition of the staff or responsibility or engagement into the quality improvement, provide them with the skills to improve the service altogether. And it cannot be just a select group of the people. So if you're engaged, then the whole processes in the department can be taken care on by the health quality improvement. Institutional reputation, yeah, this is ultimately, so as processes are improved and the systems, ultimately the ranking of the institution may be on a higher side, can be trusted by the community or trusted by the clients, trusted by all those stakeholders that may join into getting the service or for any engagement that may happen. So these are the importances of the quality improvement. I'd like to end up here And if there are any questions, you may reserve to the end. I may welcome my colleague to continue from here.
Thank you so much, Dr. Akrabi. And thank you everybody for being here. So full disclosure, like Dr. Akrabi said, QI is not something that we can discuss, do justice to in 1 hour. So this is just a very brief summary. Hopefully we'll have more opportunities in the lecture series, in the MUHAS lecture series, to delve more deeply into the nitty-gritty of the QI processes. But because of our time, I'm just going to dive in. So Dr. Akrabi has made us to understand what QI is and why it is very important, and very importantly, how to differentiate quality improvement from quality assurance and research. I am going to be focusing on a core QI framework called the Model for Improvements. These are tools that we can use to help us to design and identify improvement interventions. So what is the Model for Improvement framework? The Model for Improvement framework is a core QI framework that is coined from the IHI, the Institute of Healthcare Improvements, that helps us to do basically quality improvements. So what exactly is it? It's asking us 3 questions for every improvements, quality improvements efforts. What are the 3 questions? The first question is, what are we trying to accomplish? What do you want to do? What are you seeing in the ED that, this process can be better? We're doing it, but I know that we can make it better. So that's the first question that the Model for Improvement wants you to answer. And then the second question is, how will you know that the change that you want to make will actually improve the process? And then the third question is, what are the changes, what interventions, what are the things that you can do that will bring about an improvement from what you have decided you want to improve in the ED? And after you ask yourself those 3 questions, then it tells you to go and test it out. And I think Dr. Akrabi already mentioned that in the PDSA cycle, which just stands for plan, do, study, and act. So let's dive in. What are we trying to accomplish? That is our aim. I see that in the ED, we have a lot of patients. It takes a long time before the patients come from the triage to see the physician. How can we make that process faster? Maybe it takes 60 minutes, it takes 70 minutes. We're doing our best, but are there things that we can do to make it maybe less than 30 minutes? So that is your aim. What are you trying to accomplish? And then the second question, how will you know that a change is an improvement? Those are your measures. How will you know that if I do this, it's actually going to bring about an improvement in patient flow? And then the third question, what changes can we make that will result in an improvement? Basically are your interventions. What are the new things that you're going to be doing? What are the things that you're going to be adjusting? And then obviously we test it out, like I said. Alrighty, so the first question, what are we trying to accomplish? I have to emphasize here that for you to know that there is a problem, or that the problem that you want to improve is a problem, you have to have data. And data is so important. And what do I mean by data? Edward Demings, this is a quote from one of the grandfathers of QI. He says that without data, you're just another person with an opinion. I can come and say, oh, why is everything so slow here? That's my opinion. For you to be able to prove to leadership, prove to the departments, prove that this needs to make a change, you have to be able to say that we have looked at the data and we found out that within this time period, we're having this is a repeated or a recurrent problem. So for example, and then something's like, well, how do we collect data? Data is hard to collect, and I always say that in QI, it doesn't have to be elaborate. If you decide that, I think that patient flow is a problem, you can decide with your group to say, why don't we do for the next 1 month, maybe we'll try and measure the time it takes from when the patient comes into the triage to when the patient is being seen by the physician. The point I'm just trying to make is that you need to have data to be able to prove that there truly is a problem. Because when you have data, then you can prove that, or you can also show that when you make an improvement, there's actually been a change. And then the second thing that's so important in quality improvements to make sure that you have a successful quality improvement is to make sure that it is a problem that you can fix. Many times as physicians, we have grand ideas in the ED. We want to do good for our patients, but sometimes we have to needle down and pick fixable problems. And that is what QI specifically helps you to do. So how do you choose a problem? You have to combine your passion. I really want to change this. I really want to improve this in the ED. And you have to combine that with what is feasible, right? So for example, if I wanted to say that, I want to improve the patient flow from presentation to being seen by the physician. One of my ideas could be that, why don't we build a new wing in the MUHAS EMD? Now that's a great idea, but is it feasible in a short time? Is it the reality? That may take a little bit more effort, more time, and that probably will not be a successful QI project in that short instance. So basically, choosing your problem involves understanding what you want to solve and combining it with what is feasible. So usually we always say your problem should be simple for quality improvement. It should be easy to fix, and it should be amenable to change. It should have value, right? You want to do something that will make an impact, like the title of our talk, small changes, but big impacts. For quality improvement to be successful, you want to choose problems that do not need many new resources, but that only optimizes the current resources that you have and is able to tweak it in such a way that it can bring about improvement or changes. And quality improvement also, you want things that have a short turnaround time. He talked about research. That's why we wanted to differentiate it. Research is things that are long-term. Quality improvement are things that you want to do now, test it, and see if it makes an improvement, and then implement it. And so you want to avoid rare events, and you want to avoid long-term projects. Alrighty. One of the QI tools that is very good in helping you to choose your problem is something called the PICK charts. PICK. That stands for possible, implements, challenging, or kickouts. And as you can see on the x-axis and the y-axis, it talks about the impact. So something that is easy to change and has high impacts will be something that you want to implement, right? And something that's something that is very, very hard to change and has a low impact is not a QI project that you want to do. So let's do a few quick examples. Because of time, I'm just going to rush through it. So I'm going to put in all my examples, and then we'll talk about like one of them. So a QI project that is probably has easy to implement and has high impact will be a problem like, how can we, I've been talking about that, improve the patient flow? That's going to have high impacts and relatively easy to change. Or you want to say, we want to reduce the incidence of patient falls in the EMD. That is going to have high impact because you're improving the care of the patients that the care that you're delivering to your patients, and the change, the implementation may not be so hard. And then compare that to the kickouts. Like I said, building a new wing in the EMD to designate as triage because you want to expand, you want to improve patient flow, is probably going to be a hard QI project to complete within a short frame of time. So that is not a QI project, for example, that you want to choose, or an intervention in trying to solve or improve a process in the EMD. Alrighty. And then after you identify your problem using the pick charts to know what you want to implement, now you want to decide, what is my aim statement? Quality improvements, you need an aim statement. That's the unique thing about quality improvement. It has to be done in a particular method. And for aim statements, we have our global aim and we have our SMART aim. Because of our time, I'm not going to talk so much on the global aim. The global aim is just your general, broad overview idea of you want to improve. So like, say, I want to improve the patient flow. It's not really specific, but it gives an idea of what you're thinking about. And then your SMART aim, which I'm sure many of you have heard about, is a specific, well-defined aim that has measurable objectives that can be tracked and evaluated. And it has to encompass the 5 whys. So that is the who, the what, the where, the when, and the why. And it helps you to drive home and needle home your points. So just for the SMART, the mnemonic, it's specific, it's measurable, it is achievable, it is relevant, and it is time-bound. So an example, I've kind of been talking about it just so we kind of have a flow. So let's say I want to improve. I come to the EMD and I think we're doing our best, but I think we can do better. We can improve the time it takes from a patient coming into the EMD to being seen by the physician. Like I said, that is a global aim. It's just a general aim. How do we turn this into a SMART aim? Remember, specific, measurable, achievable, relevant, and time-bound. So we can say by June 2026, we want to reduce the time that it takes from the presentation at triage to the initial physician assessments in the Muhimbili EMD by 30% in order to improve patient flow and enhance timeliness of care. The things that stand out here is it is specific. We know exactly what we want to do. It is measurable. We're saying we want to improve it by 30% from our baseline. Your baseline, how do you get your baseline? That's what I talked about. You need to have some data. And then, is it achievable? I think so. It's a good, reasonable problem that has high impact to the customer. It is relevant, right? Because you want to improve patient outcomes, and it is time-bound because we've given ourselves a time. We're saying that by June 2026, we want this to happen. Another quick example, and this is actually something that was actually done in the MUHAS EMD, where the problem was they realized that patients were falling, and they wanted to prioritize safety by preventing fall. They did this from November 2024, and I think they're still working on it right now. And so to make this into a SMART aim, same thing, from November 2024 to December 2025, we will reduce the patient falls in the EMD by 50% from baseline through implementation, same thing, specific, measurable, achievable, relevant, and time-bound. Now, after we have identified that problem, before we jump into how do we fix this, we have to understand, why is it a problem? Because if you don't understand why the problem exists, then your interventions may be dealing with the wrong reason. So for QI is a stage process for it to be successful, right? So you want to understand, why is it that there is a delay? Why is it taking 2 hours for patients to be seen? What exactly is the problem? In QI, that is called root cause analysis. Basically, you're trying to figure out, why is it a problem, right? And the QI methodologies for root cause analysis, there's so many, but because of our time, we're only going to talk about a few of them. So one of them is called the 5 whys. And the other one is called fishbone, also known as an Ishikawa diagram. And we're also going to talk about process mapping. So what is a 5Y? Basically, a 5Y is like you have an onion, right? And you're trying to peel the layers of the onion until you get down to the core. Why is it a problem? So this is a very quick, simple example, just to give an idea of how 5Y works. And basically, you're asking at least 5 Ys, like why, to get to the roots of the problem. So in this example, in this restaurants, the problem that they identified was that they were having a lot of bad reviews. The customers were mad, and they were getting bad reviews. And so the management, they came like, why are we having, so they started doing the 5 Ys. And so why are the customers mad? Why are we having so much bad review? Well, when they asked themselves, the team, they found out it was because service is slow. And then they go, next why? Why is the service slow? Well, service is slow because when they put in their food orders, it's late. Okay, why are food orders late? Well, when we looked at it, it's because the chef isn't cooking. Okay, why isn't the chef cooking? Well, because he's busy washing dishes. Why is he washing dishes? Well, because they ran out of plates. And so I know this is a very simple, but for you just to get the how a 5Y is done. So really, one of the major reasons why the customers are mad in this particular restaurant is not because the food isn't tasty, it's not because they don't have good service, it's because they don't have plates. And so going through that 5Y helps you to identify some things that you may not even think is a problem that can actually improve the process. So in this particular problem, all they had to do was get plates. And when they got plates, then the chef doesn't have to be distracted. So just an idea to understand how you do a root cause analysis. The other one is the fishbone diagram that helps you to identify contributing factors. Some of the things that I didn't mention because of time is that for QI, you also have to assemble your team. So you're doing this with your team, after you figured out the problem that you want to solve. And fishbone, basically, there are 6 core elements that you want to identify, that you want to, as a theme, as a subheading, that may be the reason why you are having the problem. So the causes right here, giving rise to the effects. I don't know why that red line is there. I apologize for that. And so you talk about the equipment, the process, the people, the material, the environment, and the management. So quickly, the example that we're talking about, our problem statement, which is we want to improve the patient flow from presentation to being seen by the physician. So in this example, if we wanted to break it down under people, policy, methods, equipment, environment, but basically you're saying under these categories, what are the things that are contributing to the problem? So for example, in the people, maybe we're understaffed. That can definitely make there to be a delayed time from patients coming into the EMD to being seen by the physician. Or maybe we don't have, maybe there's variation in the skill. Maybe we have some nurses who are, they're very good. Maybe some nurses are new, and so they've asked too many questions, they delayed the process. So maybe because there's not something standard, maybe that's why. You look at the policy of the EMD right there. Well, maybe we don't have protocols, so everybody just does what they want, you know. Methods. Maybe we need to design a system that helps to be able to identify patients that are not so sick that we can see quickly and have a disposition so that we can leave time for the really sick patients. And you get the point, Basically, this helps you to try to identify what may be the reason why you are having your problem. And the reason why this is so important is because when you look at it in this visual diagram, then you are able to actually come up with ideas. You're able to come up with interventions that you can actually apply or test to see if it actually improves the process. So for example, you may decide, I'm going to pick on people and I'm going to pick on policy. So maybe we need to do a color code to help the triage nurse so that there's some form of standardization. There's no variability about how to triage. Or maybe we want to look at the policy and we want to do, okay, I'm going to stop doing that. I think it's my mouse. And we want to we want to improve stats protocols. When we want to do SOPs, that is going to improve the flow, you know. So looking at the fishbone diagram helps you to come up with ideas that you can actually implement that will help to solve the problem. Okay, and then your process map, basically it's the QI people talk about, they use the term a Gemba walk. Basically you want to see what the process is currently, right? So for example, if the problem we wanted to solve is improving patient flow from presentation to physician, you want to have a visual representation of the current process. So your team, if this is the QI project you wanted to, whatever QI project you want to do, right? When you come up with your team, you're like, let us see how does the process work now? Walking through the process helps you to identify places that, oh, maybe we don't need to do this step. Maybe if we eliminate this step, we can improve the flow. It helps you to see steps that maybe are being duplicated. It helps you to see bottlenecks. It helps you to see unnecessary complexity if you actually walk through the process. It helps you to see waste, places that we can eliminate, or places that, oh, this is a good part in the process that we can emphasize. And usually, like I said, you want to engage your frontline staff. So this is an example of a process map. This is a very, very simple example. But like I said, I just wanted to use this just to kind of give you an idea of how we think about of root cause analysis, specifically process map in QI process. So I really don't know how so forgive me if this is not done properly. Like I said, I just need to give an idea. So if you wanted to do a process map for patient flow in the EMD, for example, you start from the patient arrives on the left-hand side, and the end point on the right-hand side is that the patient is being called by the nurse to the room to be seen by the physician. What are the things in the process, when the patient arrives, are they greeted at the front desk by the registrar? Do you have to do a pre-registration? Do you have to collect information? Looking through the process like that in the X-ray version, like trying to see every step, will help you to identify areas that you can improve, areas that you can eliminate to reach your goal of improving the process. I need to move faster. Alrighty. So now that we have answered our first question, the second question is, how will we know that the change is an improvement? Remember that I said that how you will know that the change is an improvement is your measures, if you remember. So you have to be able to say that, how will I know that the change that I'm making is improving the process? How will I know that how will I measure it? That if I do this, it's actually going to improve. In QI methodology, you have 3 measures that you must have for QI. One is your outcome measure. The second is your process measure. And the third is your balance measures. Your outcome measure basically is your aim. That's what we already talked about. What do I want to improve? I want to reduce the incidences of fall. I want to improve the patient flow. That's my outcome. That's what I want to get at. Now, what is my process measure? My process measure is what are the things that I'm going to do that I can measure that will show me that I am reaching my goal of what I want to do. Like I want to improve flow, I want to reduce falls. What are the steps? What are the things that I'm doing that if those things are improving, then I know that I'm improving my outcome measure. I'll give you an example. And then what are my balance measures? My balance measures are my unintended consequences. In my bid to do good, to improve a process, I want to be sure that I am not inadvertently causing some side effects, some harm. So what do I mean by that? Let's give a quick example. Okay, so still with our hypothetical example, which is that we want to improve the patient flow in the EMD. So what is our outcome measure? Basically, I want to reduce the time that it takes from when the patient presents to when the patient is being seen, right? And so that's my outcome measure. The time, maybe it used to take us 2 hours, maybe it takes 150 minutes. And I'm like, that's not good enough. This team, we want to make it 30 minutes, let's say, let's give it a time, 30 minutes. So my outcome measure, my goal is I'm measuring the time. I want it to change from 150 minutes to 30 minutes, right? So that's my outcome measure. Or you could also say, I want to improve the number of patients that are being seen. Maybe in the past, maybe only one patient gets to be seen by a physician in 30 minutes. And now I want to make it 5. So that's my outcome measure. What are my process measures? What are the things that I'm doing to reach my outcome, right? So that, for example, will be, an example of a process measure will be the percentage of patients that are triaged. So for me to improve the time the patient gets to the physician, that means that the time it takes for triage, maybe triage should take 60 minutes. Now we're putting in processes together. Maybe we have an SOP, we're teaching the nurses, they have like a color-coded thing that helps them to know how to triage the patients. That is the process, because when they do that, it reduces the time for them to complete the triage, which will inadvertently reduce the time for that patient to be seen by the physician. I hope that makes sense. And then what is your balancing measure? Your balancing measures are your unintended consequences. So for example, because now everybody is just trying to, this is what we have to do this, are we missing sick patients? Are we, because we are being quick, are we now having some incorrect triage acuity because we're trying to be good? So a QI methodology makes sure that we're balanced, that we're not sacrificing accuracy for efficiency. So that's how you put the outcome, process, and balancing measures together. Okay, so now that we have talked about our measures, we've talked about our question, we've talked about our measures, then the third question is, what are the changes that you could make that will result in an improvement? This is the fun part. This is the part that I know many physicians like. This is the part that now, what are the interventions? What are the things that we can do to improve the process? Process mapping is the same thing that we talked about, where as you look at the thing, you are now saying, oh, let's do this. We can do this because you've identified areas that you can improve. The main one that I want to talk about is the key driver diagrams, called a KDD. The KDD has 3 components. It has the objectives, it has your key drivers, and you have your interventions. It basically helps you to organize your ideas in a way that you can achieve your aim, right? So this is basically what a key driver diagram looks like. You have your aim on the left-hand side, and then you have your interventions on the right-hand side. And in the middle, you have the things that those ideas are influencing to bring about your aim. Let me give you a quick example. This is a very, very busy slide, but I wanted to put this in here. I'm going to give you like 30 seconds to kind of just, look through a few of them, right? It basically helps you to classify what I'm talking about. Your change ideas, your interventions, that drives your secondary, primary drivers to reach your aim. So this same example that we've been talking about, improving patient flow, with your team, you may decide maybe we just need to have standardized processes, based on your fishbone diagram, you identified a few things. Based on your process map, you identified a few things. Maybe we need to work on the front end parts, like the triaging part. Maybe we need to make that a little bit more neat, make that a little bit more tighter. And then what are the secondary drivers for that? I'm just going to pick up one because of time. I'm afraid to do my mouse because of the, okay. So maybe you say, I want to reduce variation in nurse triage decision making. If I do that, that's going to help to standardize the process that will lead to my aim. How do we do this? Well, we can create an SOP that tells the nurses what they're supposed to do. We can do we can put some common problems that commonly come to the ED and say, if it comes this way, this is the triage that we're going to give them, and this is what they're going to see. That kind of helps to move things along. For the front end, maybe we want to say, maybe we want to take one of our medical officers or junior residents, or a tech, or somebody who is well trained, or a nurse that's well trained, to do kind of like a fast track, and that way that will help to create a space for the low acuity cases to be seen on time, which will improve the front end, which will end up improving and helping us to reach our smart aim. So this is a busy slide, I know, and I apologize, but it's just a good, I felt it was a good visual for you to see, to have an idea of what I mean by doing a key driver diagram. Alrighty. And then finally, after we've done our third question, then we go to the testing. Now you want to test it out. That's your plan, do, study, act. Remember, QI is different from research. QI, you test it out in real time and then you implement. Now, what are the unique things about PDSA cycles? Is that you want to start small. When you have a great idea, you don't want to immediately say, because you don't know if it's going to work, right? So you just want to say, oh, Dr. Juma, I have this great idea. This is what we're going to do. We're going to start it. No. That's not what you do. Your team, you start small. You come up with your team. You say, like, we're going to test this on Monday between morning shifts, a group of us, and then we're going to see if it works. We'll test it. If it works, maybe it works because it was morning duty. We're going to test it in the nights. If it works, and we've done it multiple times, then we're like, okay, maybe it works. Now you can say, let's talk to Dr. Juma and see how can we truly implement this. And so PDSS cycles are good because you learn from each cycle and you're able to share the lessons with the team. So say, for example, you wanted to, part of the KDD, we wanted to test, what I talked about, that maybe we get a nurse or junior medical officer to do an initial medical screen. We don't know if it's going to work, but we want to test it out. So we do a PDSA cycle. What do we mean by a PDSA cycle? Oh, this is the wrong slide. I should have checked it to the very end. So the PDSA cycle basically means that you are, the 4 outcomes of a PDSA cycle. It could be when you test it out, are you going to, when you tested it out, it worked great. Are we going to adopt it? Yeah, so that's when I said, you test it out, it works, then you tell Dr. Juma. Or when we did it, oh, it was a total mess. It actually made the patients, it actually made the time longer. They actually, so you're like, oh no, this is not a good intervention, scrap. now we have to come up with another intervention. Or it worked a little, but there's some things that we could do to make it better. And in that case, we need to adjust. So those are the 3 outcomes that you can have with a PDSA cycle. You can adopt, you can adapt or adjust, make some changes, or you can say no, you can eliminate. Okay. Now, what are the common challenges that we have with, and how can we solve them for our QI projects? One of the common challenges that we have, which I'm sure you're familiar with, is frequent turnover, staff rotation. So you've done an SOP, you've done training, and then after you've spent and invested time, half of the staff that you trained are moving to another department. And so you have to restart again, And so the best way to solve a problem of frequent turnover is to have established protocols, right? That even if a new staff comes in, they just, like before you, like part of your onboarding, you have to do this, you have to do this, you have to do this to get into, to work in this place. Limited equipment is also a major challenge. I've been to Muhimbili, so I know that can be a major challenge. But what I say as a solution to that is to optimize the existing tools that we have. One of the reasons why this is important is because it can help you to advocate. If you keep saying we don't have enough tools, we don't have enough tools, but if you do a QI project and you're able to prove that if we had this, we can do better, you're able to advocate to the leadership to let them see why this should be priority in terms of bringing more equipment. But in the meantime, you want to optimize the existing tools. Data collection, but it doesn't have to be fancy. Simple checklist, Excel is something that, we can start with at the very beginning. Sustainability, the best way to overcome the challenge of sustainability is to do the train the trainer model. And how do we sustain improvements? Regular team meetings, doing visual data feedback, celebrating your small wins, embedding quality improvements in your daily work. Very important is getting your leadership to be involved, engagement and accountability. Finally, I want to mention that QI in limited resource settings is very possible. It doesn't need to be complex. You saw the examples that Dr. Akrabi gave us in his part of the presentation that were successful, impactful projects that were done through quality improvement initiatives. So it doesn't have to be complex. It doesn't have to require significant financial inputs or system overhaul. Sometimes a small change can lead to a large adjustment in creating a culture of safety. And I believe that as global technological advancements are coming up, I believe that this will create new opportunities for enhanced data collection, communication, and patient engagements. Finally, I just want to talk about, I don't have time for this, I only have 1 more minute. The MNH EMD example, which, just proves that small changes can truly make a big impact when you do quality improvement initiatives. So the MNH EMD had a problem. They felt that a lot of their patients were falling and they wanted to meet the standard, the safety standard for falls, right? And so they came up with a QI project. They wanted to prioritize the safety of patients by preventing the incidences of fall. And they came up with a beautiful process aim. There's no time to talk about it, but I wanted to highlight this key driver diagram that they did. See, that was their aim, the primary drivers, the secondary drivers, and the interventions that they did to bring about those drivers to bring about the aim, and so very proud of the EMD and MNH, where they were able to work on this simple QI projects and come up with strategic interventions that help them to reduce the incidence of fall in the EMD. Thank you very much for your attention. Please let's continue to build a culture of improvement. And Dr. Akrabi and I will be happy to answer any questions that you have. Thank you.
Yes, thank you very much, Dr. Ali and Dr. Bola, for a wonderful presentation. And I'm sure the participants that have joined us today, they have learned a lot, and wherever they will be working, I'm sure they could apply the knowledge that we have learned today just to do simple quality improvements within the areas that we work. It could be in an emergency setting, which I know the majority of us are coming from emergency, but this does not apply only to emergency care setting. It's something that can be applied at any setting. So we still have 5 minutes. If there is any question that our participants have, or if there's any clarifications that you might need from Dr. Bola or Dr. Ali, either you can put it on the chat or you can just unmute and ask. So if there's anything that you really want to ask, you can just place it on the chat or feel free to unmute and ask the question. We still have 4 minutes. As well, as I say, this is a CPD accredited activity where we'll all get 3 CPD points. Just make sure that you've written your name and your registration number on the chat so that we could claim it for you. But just remember, you should not have any debt at MCT so that you can be allocated the 3 CPD points. As we still have 4 minutes, just to make a reminder, this is our 11th PEM lecture series, and we conduct this every month. And it has been very successful, and we have been learning a lot. For next month, that is going to be December on the 10th, we're also going to be having an interesting topic that is going to be speaking about simple or minor pediatric procedures that are performed at the emergency department. So I'd like to welcome all that have joined in today to stay tuned for our next presentation and probably get prepared. You can read along just to come up with questions. But as always, we'll keep on updating on our social media. And all these PEM lecture series are also recorded for reference. So I've sent a link, a YouTube link that you can always hop in and just check in when you want to refer or review. So we have a question on the chat, which says, how do you ensure sustainability of quality improvement initiative when project ends as healthcare workers seems as its additional task?
Thank you very much. Oh, sorry. Thank you very much for that question. That is actually a very important question because you do want to be able to sustain improvement. Some of the techniques, the suggestions are that so the team, so typically for a QI project, you will have like a QI lead, right? Somebody who's a champion. So you want to make sure that you probably wouldn't be meeting as much, but you want to put some things in place that helps you to identify when the system is beginning to slip and so that you can quickly intervene. So having team meetings, maybe not as regularly because everybody's busy, after the project is successful. So maybe every 3 months, we'll just go back and look at the data and make sure that, we're still on track. So keeping an eye on it, not ignoring it, not putting it on the back burner is one of the ways to ensure sustainability. The second one is to have, like I said, I like to call them make the easy thing, make the right thing the easy thing to do, make the wrong thing hard to do. So putting systems in place. So for example, having a standard operating procedure, for example, having a checklist, right? Having somebody who is in charge of making sure that those SOPs or those checklists or whatever things that you did to standardize the process is being used is another way that you can sustain projects. The third way is one of also the most important is making sure you have leadership involvement. You know, when you have leadership involvement, such that it becomes part of like the in this particular setting, the leadership, the hospital has said we need to meet this standards. Those are the things that help to inspire or move people to do the right things. So those are three ways that I can say are one of the easier ways that you can maintain sustainability. Regular team meetings, making sure that somebody is keeping an eye on the process. Maybe not as frequently as during when the QI project was being done, but making sure that we're not forgetting about it, because you know how it is. When you forget about something, it starts to sleep. If you keep an eye on it, when it starts to sleep, you can quickly intervene before everything scatters, right? And then, like I said, embedding it, making it hard to do the wrong thing, making it easy, putting processing in place to make it easy to do the right things, and then making sure that your leadership is engaged and involved and approving. It usually helps to sustain improvements. Thank you for that question.
Thank you very much, Dr. Bola, for very nice elaboration. And I would like to thank all our participants that have joined and our presenters, Dr. Ali and Dr. Bola again. It has been a very nice presentation and we are right on time. And I'd like to say thank you all and have a good evening and a good morning to our colleagues in the US.
Thank you very much. Thank you, Dr. Akrabi. Thank you, Dr. Humphrey.
Thank you very much.